open for us with a word of prayer. Father, thank you. Everything that happens. Thank you for the food. Amen. So with that, I'll start with the person speaking on my left side so that we just introduce ourselves, and from there we'll continue. So we start with you, Mr.
Born in Uganda, raised in Kenya, greatly
Production.
Gono, I'm a biggie. Supercell warrior. That's 2 years. Yes.
Yes, Supercell.
My name is Michael Onyonyi Martin, and I'm a warrior, also a SCAT member. Thank you.
And Mr. Sickle, sir.
Yes.
Good morning. My name is Tom Dibuku, Associate of SCAT.
Good morning once again. I'm Gati Kamero. I work with SCAT Kenya. Karibuni sana.
We will skip to you, Mr. President, because we will introduce you properly.
Okay, my name is Edward Consolo. I come from the Stroke Association of Kenya, being a survivor of stroke for the last 11 or 12 years. I'm also a member of the NCD, or Non-Communicable Diseases Alliance of Kenya board. So I'm happy to be here.
Thank you so much. And I wanted to introduce you the last part as you come to speak. But because I'm the one starting there, let me just introduce yourself, but I'll introduce you again when you're coming to speak.
Good morning, everyone. My name is John Gikonya. I'm a friend of
Sawa, thanks. So now at least everybody knows each other, and from there we'll continue. Yes. Who? Oh, yes. Our able photographer and videographer. Kindly introduce yourself. Yes, so we are grateful and we are going to start. Candy can send the link so that Katie can share. And also, as I begin, my name is Eunice Ovino. I'm the founder of Sickle Cell Uhuru Trust, where we call it SCAT, Kenya, and also international. So we began this journey 10 years ago. And as we still continue to mark 10 years in the sickle cell advocacy space, it's my honor and pleasure to invite again each and every one of you to take time off your busy schedule to come and join us. And this training that we're doing today, it's a training that has been sponsored by World Patient Alliance, where SCAT is a member. So SCAT is not only a member of World Patient Alliance, but we are a member of many other organizations. Locally, we are a member of two organizations. One is Sickle Cell Federation of Kenya, and the other one is Non-Communicable Disease Alliance of Kenya, where I sit as the secretary for the patient-led organization caucus. So that is representing all the patients very well. And also we are represented in all the 17 counties that are highly affected with sickle cell disease in our country. We are also represented globally with our able co-founder Ruth, who is not with us here, but she's in Norway, and I know she'll catch up online. So yeah, and also internationally, we are members of like 5 organizations. Yes. So SCAT is continuing to grow. So we continue to urge you to continue being our members so that we continue doing what? Growing and growing every year. So that is SCAT. And today we are here to talk about World Patient Safety Day, and also just knowing the importance, because if you see their theme this year is to improve diagnostics for patient safety. So I'll be handling the topic of diagnostics, misdiagnostics, and the challenges we usually have. So with that, now my Betty, you go to the next. Yes, so misdiagnostics of sickle cell disease. The common reason that we always also know that sometimes you get misdiagnosed with sickle cell. One, when you don't so because again it overlaps with other diseases. That's why sometimes when you have a sickle cell episode, you find that you're told you have malaria, and they'll test for malaria first instead of testing if you're having a sickle cell pain. But because they don't know you have sickle cell, they'll test first malaria. That's why it's saying a common reason for misdiagnosis is usually symptoms overlapping each other. And these symptoms are like, Valentine, you can tell us what are the symptoms? Joint pains. So when you see joint pains and losing breath to breathe, it means you have malaria. So it overlaps. They'll not see sickle cell per se. What are they going to? The doctor will diagnose you with what? With malaria. Reason being joint pains. And that time, the joint pains are being caused by a sickle cell crisis that you are episode you're going through. So again, that's why you as a patient, you need to know, do I really have sickle cell? When I have crisis, where does it pain me? Is it my back? Is it the joints? Is it my legs? So again, because when you are explaining, sometimes that's where we end up being misdiagnosed, because also when you don't know, and also your doctor doesn't know that you have sickle cell, you'll always be treated with malaria. So after that, then also failure to understand the family history. If you're told, like in your family, how many of you have sickle cell? So if the doctor knows family history, it can also help for them to get the right diagnosis. If they don't, then it means they fail to understand that you have sickle cell. And throughout your life and pain, you'll be always be treated that you have what? Malaria or malaria. And then also just inadequate testing tools that we have, because in we actually don't have a lot of what is it called? We don't have a lot of HB electrophoresis in all regional hospitals. So it becomes a very big challenge for us to be able to get the right test that we are taken through. So when you see all this, these are just myths because people don't understand, and that's why we need to advocate as patients so that we know. And am I being misdiagnosed right now, or am I being given the best diagnosis? So my next slide.
Before we move.
Yes.
This diagnosis can also be adapted.
Yeah.
So what you have treated here is you have sickle cell, but the doctor thinks you have malaria.
Yes.
But you could actually have malaria, and the doctor thinks it is a normal sickle. It's also another myth.
Yes, yes.
Then, so you be treated for sickle cell, malaria is less than 100, then you have.
It's true. Actually, when you have malaria and you have sickle cell, the two don't, can I say they don't marry? Because that is the worst time as a patient you can go through. Because malaria actually makes all our sickle cells come out very strongly, and then the body is really trying to fight, which the body can't fight. So you end up having a very, very intense battle that you're fighting. Again, if you don't get quick or you're not treated immediately, it ends up that you end up now starting to have issues with your organs. Yes. So when you start having issues with your organs, then we end up having diseases like stroke, kidney failure, issues with our eyes, issues with our heart, issues with diabetes, hypertension, and all that. So sickle cell is just a disease that, again, because of prolonged pain, it brings another disease altogether. That's why I always like the vision of NCD Alliance of Kenya that say, let's have a free NCD NCD free Kenya. So that's why it is important as people to know which what are you diagnosed with, and how should the diagnostics look like as a patient, not really just doctors, but you as a patient, so that you know, so that people don't come and say, this one looks like that is malaria, but they have not really diagnosed, or they can just assume you have malaria. Well,
Yeah, so it becomes hard for you even to be diagnosed.
so that is a challenge, because now it comes back to us educating the healthcare practitioners. And how many of them are receptive when you tell them that I have sickle cell? Because that is the reality. When you tell them, number one, because you yourself, you have taken care of yourself for many years. Then you tell them, I'm allergic to a certain painkiller. How many of them usually just accept that that is the reality? Or they'll tell you, if you knew this, why wouldn't you have treated yourself where? At home, instead of coming to tell us our work. So how can we help them? Because now that comes the part of solutions. Because we don't also want to be part of the problem. We want to be solution givers. So as we're giving them solutions, how can we talk to the healthcare workers so that they understand that when I'm coming to the hospital, I'm not coming because because I've heard the word of you are a druggie, you are a pretender, and you just love morphine.
I think they can be told that for us to, by the time you get into hospital, not that the pain has started to happen. Most of the time you find you had this pain for a while, try to manage it at home, and not working. So that's why we hospital to keep further help. So they should understand that when we come and tell them that this drug and this drug doesn't work, it's not that we are looking for a certain drug or we are addicted to a certain drug. So this is something we've had for most of our life, and we know what works for us. So they should be understanding to what we are telling them.
Okay. And also, who else can add? Eddie? Eddie?
Okay, now I'm assuming if you are living with or any other condition, the reason you have to explain to a doctor is maybe because this is not your regular doctor. Otherwise, if you're in a sickle cell clinic, there should be no issue.
Yeah.
Or a renal clinic. So the reason you're explaining is because probably you have an episode and you have been rushed to the nearest health center.
Yes.
And there you have to speak up and explain, I'm a sickle cell patient and this is how I should be treated. It would also help to add who is your doctor. Tell them I go to XYZ clinic and Dr. XYZ is my doctor. So can be contacted. Then there can be instances where you are not even conscious to speak for yourself. And there is therefore a very great risk to be given a treatment which is not corresponding with what has made you unconscious. It is helpful to carry with yourself a card. I think I've left my wallet in the car. I would have shown you. There's a card I carry which has all that information. It has who you can call in case of emergency. It has the drugs that I take, and it has my doctor's number. It even says text the doctor because I know he does not pick calls from strangers. But if you text him and tell him we have found this card on a patient and he says 1, 2, 3, he will respond. So that is in case you're in a place where you can not speak for yourself, whether you are conscious or something. So that you are not taken to a place and you are not given the proper treatment. The reason I walk around with that card for my case is because I live with a kidney transplant and I have to take medication for prevention of the kidney rejection. So if I get it, say, God forbid, in an accident, and I'm unconscious at KNH as an unknown adult patient for 3 days, I'll be staring at 2 emergencies, but they will only be seeing one. You'll only be seeing the injuries and the unconsciousness. But now I'll be 3 days without my post-transplant medication, which means there will be a rejection. Because I don't want that to happen, I usually carry that on me. Now, also don't put it in your wallet, because the people who come to rescue you, you know, they are Kenyans. You know what they will do for it. They will take your wallet. So have it somewhere else on your. You can have it as a ring or a bundle, or even you can create what is coming just now, what do you call it? A QR code which can be scanned and it gives all that information about it. If you want to have a QR code as a tool or something, but make sure that you'll be able to speak for yourself even when you're not conscious, so that you are not misdiagnosed or kept in a hospital where you're not giving the treatment that you require and they're only responding to the emergency that took you to hospital.
Thank you.
add on what you said, just that sometimes when you cannot speak for yourself, but there's someone that has taken you to hospital, you make sure that that person knows the condition and the diagnosis and the pain meds that you're supposed to be given at that particular time.
That is your schedule.
Yeah.
But again, it depends. Where are you? If let me picture a scenario. If maybe you're in school, or maybe you're leaving school going to home, you're going from school to home, nobody knows that you have sickle cell because sickle cell is not written on our faces. NCD is not written on our faces. So if you get an episode, and for me, one of the solutions I'm thinking, and let me ask the question first, like now, how do you handle that case? You don't have anything saying you have sickle cell, you're having a bad crisis, what will happen to you?
That's where, when you get into okay, most of the time, the situation that you have just described is maybe you have, let me just say the worst case scenario, you fainted. You cannot even move. So it's just strangers helping you here right now. So I'm thinking they need to make you conscious first, so that at least when you get conscious, you try, even if you cannot speak, you try and elaborate what you're going through.
Okay. But one of the solutions I was thinking is, can we make like the way President John has said, in terms of, can we make like a sickle cell wristband where it says, yes, I have sickle cell, and when I am sick, this and this happens to me, or this is the way he has said, this is my doctor, and all that. Do you think that is a solution we can think about as sickle cell community? Can we have like, because in Tanzania they have something they call a passport. So with the passport, it has all your information, where you stay, who is your next of kin, when is your next clinic visit, who is your doctor, what is your blood group, and all this. Do you think we can generate that and run with it as a solution for us in Kenya?
Yes.
Yes, we can, but I would go about it from an NCD. That's one. Reason being, it will be an intensive program. Of course, you're not just going to wear this or the QR code. You also need to educate the healthcare worker, to organize it, and to know what to do with it. So for that to happen, it will be a very huge task for one disease. So I would propose we tackle it on
NCD.
So that now local organization, they are on it, diabetes, and it applies to all people.
Okay.
So that's a project you can take one way or the
That's a good
Part
solution.
of that, maybe we can have like a database whereby as much as you can have a QR code, but if you scan and it doesn't give you a link to anything, right? So we can have a database, and now from this database, it's like everyone's name is on it, and on that maybe your patient, your name, your next of kin, which hospital you go to for your checkup, name of your doctor, doctor's contact, blood group, and also like in an emergency, which meds, which painkillers, like sometimes you might be on the road, you get a crisis, so you need to go to the nearest health center, like which painkillers will work for you, such that All those details can be put in on that passport, and then also on the database. Then a QR code is generated whereby anyone can scan it, get your details, know, okay, this patient's name is Silas, he has sickle cell, he's from Nairobi, this is the next of kin, so let's call the next of kin. Maybe the next of kin is not available. Okay, you can see the doctor's details are here. Let's call the doctor. The doctor again is not available. Okay, so here we see this patient is in pain. So when the patient is in pain, the patient is given ABCD. Yeah.
And for me, what I'm thinking also as a solution, the way Mr. Gikonyo, you have said, it can happen like that, but don't forget, it has to have, I always call it a 3D effect. So the 3D is the patient, the caregiver, and the healthcare providers. So this 3D of mine is where now all of us sit in a room, agree. It's like bringing again all the other stakeholders together, but the three have to agree. How can, because the faster you get the patient to the healthcare service, an emergency, to get help, it means the patient will be safe and they'll be saved immediately. So like, how do we make that system be faster and synchronized? Because I don't believe that now we're in 2024. In Kenya, when you go through emergency, you will go straight away. You'll have to wait because you have an NCD and it's not seen. The thing they see is, are you bleeding? Is your leg broken? I've said, if I tell you my story, too, there's a time I went to one of our beautiful referral hospitals. In the morning I was well, I had to go home. I didn't have to wait for the doctor. Reason being, I went in at 2 a.m. in the morning. Nobody saw me because I was in very deep crisis. They were just saying, sit there, we are coming. People who are coming with accidents, being cut with a knife, being cut with pangas and all that, gunshot wounds, they're the ones who are being served. By the time it was reaching 5, my pain had to obey. We had to go home. Because the cold was not helping, you're in crisis, you're sleeping in a bench, and no doctor was busy caring. Yes, you have all your doctor details, but is your doctor very influential when it comes to, yes, these people need emergency help so that we can save? Because for sickle cell, I usually feel like for sickle cell, it's a bit, we are not saying we are special, but sometimes if you don't get that emergency help that we need as patients, then it ends up bringing other complications, which include organ damage and other comorbidities, the way doctors call them. And I've never understood why are they calling them comorbidities. Anyway, so other diseases, basically it's other diseases, because as a sickle cell patient, you can end up having stroke. As a sickle cell patient, you can end up having kidney issues. So you can imagine, like the scenario I gave you of our friend. He had sickle cell. As sickle cell patient, we're told we have to do what? Hydrate. As a kidney patient, he's told he's not supposed to hydrate. So you're getting, now how do you balance? Because if such a patient comes and maybe they are, the way Judy said, they are fainted, and you don't know they're having kidney issues, and also they have sickle cell. So as a doctor, how do you get that? Because for us, as patients, our safety is key. And that's why we are marking this day. Because it's key and it's something that we really need to push and make sure, again, our voices are heard. And they are heard at the right places. Anyway, that topic is what our dear friend will come and teach us. How we need also policies are put in place so that we get, the way I'm saying, the 3D effect of every stakeholder coming on board and making sure that you're heard. Because without that, then we'll never get the right services and be safe going through the emergency treatment. Because I believe when we have that emergency treatment, then we are saved a lot. We will never lose our organs and all that.
happens to walk into your case scenario where you want some thing happen. I'm thinking the medics are usually I think in their mind it's usually, since you are not screaming, and they usually know sickle cell patients are, they just cry because they are full of pain.
But you know, when I'm crying
Yes.
and I'm in pain, that
Yes.
means I'm adding myself stress, which does not help me.
So that's why I'm telling you, that's the reason why you went there and you were not crying, and they saw that
Crying.
they saw that you are like you manageable pain. So they kept you there because now you are manageable pain. Let's deal first with these emergencies that are coming in order so that we can treat you afterwards.
Now, if you cut your finger, this finger and it's hanging here, that is the biggest emergency unit. At that point, when you get the emergency unit experience here, that is enough.
Exactly.
Because at that point, emergency is better than So the guy who is bleeding and blood is jumping all over is a bigger emergency because so you may come with a condition that would complicate life. But on physical examination, not then
An emergency. Yes.
And that is what we are now trying to do by having a way that healthcare providers can ascertain that you may look okay, but whatever is going on would also to add that we have the digital health. We have more or less tended to health. Digital health act and there will be health records everywhere. And you will be able, your health record will be able to be retrieved anywhere in Africa. Go to any hospital in East Africa, whether you put your finger or you just put your finger somewhere, that's the health. So if that works, well and good. But what we are proposing here is just QR code you have, it is unique to yourself, and which can give a healthcare worker a very brief glimpse of who you are, the condition you have, and the risk may potentially arise for you.
What you're referring to is in terms of digitizing the information in an area where someone is not able to type. What's another solution?
You just need a phone.
Yes, we just need a phone. Not everybody is
Healthcare,
smartphone. Or maybe they'll say there's no Wi-Fi or there's no electricity.
you don't have a field of remember people who used to work in the field of saying, in case of emergency, don't take me.
You know, they'll have up to excuses of there's no Wi-Fi, there's no electricity. There's such instances of how can we get that?
No, those are some of the things we have to. Where the world is going to, and there is no way people are posting pictures from East Kanyamkago with this one. Yeah?
Kanyamkago, yes, it's in Migori County.
You cannot stand a QR. We have passed that by.
Yes, we're not speaking, but we are also dealing with people who have worked at public hospitals. To find someone who just find an excuse not to.
That's why I say that the best approach would be from global NCD because the task is not just getting it. We need to go create this code, get the database, then educate all the field health so that we can reach physically, we can reach explain to them that so that the information goes. Not to don't forget that healthcare workers also you don't want to treat someone kind of You are getting good for you. So they are so heavily invested in getting it right. They will make an effort to get on board and get a phone. You just need a phone with hand. Then a SIM card. It may scan happen. Because was scanning Wi-Fi password. Can be done. In Kasitin.
That's my home card.
Discussion is all right. And what I'm picking there is that the health workers need to be trained, to be told that this is what people of NCD are suffering from. Because even if you cry even loud, the truth is that nobody will give you attention. Because I remember one time when I took my sister to Kenyatta Hospital, and she was terribly in pain and crying as early as 8 in the morning. Up to 5 is when she was attended to. But finally, she passed on. So we need just to have that information put on the QR code, and then let the health workers be informed to know what they have to look for when you go in with this kind of disease. Thank you.
Thank you. Because also something, as much as yes, you're saying that actually the people who, the scenario and the question you ask media, it's true, because again, there are people who even stay past the island, like Mfangano Island. By the time you reach Mfangano, which is part of Homa Bay County, it's very far. And again, the healthcare workers who are there, and also the medical doctors, all the people went to a school. So the best place to target them for patient safety is the schools they go to, from universities where they are taught so that they are released to their communities, the clinicians, what are they called? The clinical officers, the nurses, the medical doctors, all of them are now brought together. It means now they'll be able to learn and understand how to narrow everything down. I think my time is up.
How much time do you have?
Oh, how many time do I have? I finish in 10. Okay. So, so thank you again for your feedback. I think I'm finished now. Reason being, I think we have covered like all the areas. But what we will do, I think we'll go first with Mr. Gikonyo. So I'll introduce him, and then he takes over. So when he takes over, then we'll finish with Daktari. So finally we have a doctor in the house. Simpige makofi. We have a doctor in the house. So you all say. So yeah. You'll know. When he's teaching, you'll know what kind of doctor he is. So it's my pleasure and honor to invite the president of Renal Patients Association Society, and also the vice chair for NCD Alliance of Kenya, and the former chair of NCD Caucus patient-led organization. So we are happy for him to come and share and teach us exactly what is our right as patients, why our voices is important, and the reason why we are sitting in this boardroom, I wanted you to feel when you go to speak to the donors or whoever you're talking to, you have a right at the table. If you're negotiating how you needed to be treated as a patient and why your patient safety is very important, when you're sitting there, you know that you own that chair. So he needs to tell us how our voices and our stories are very important, and not only to become and be rubber stamping when people are opening projects, but we need to be where the decisions are being made. Sawa sawa. Aya, tumpigeni makofi.
Thank you very much. The only thing we did not add was my M-Pesa number. I don't know why you left that detail out, but I will share it. Oh, yes, thank you. So, disclaimer, I'm not an expert. I'm a kidney patient. Okay, I'm a kidney patient living with a transplant. I got a kidney transplant in 2015 after suffering kidney failure. So I'm a patient like all of you. I don't have I don't have, Sawa sawa. So mimi sio mtaalamu ati wa mambo ya gonjwa ama nini, but I have been in the face of patient advocacy since 2018. And that's where I've come to meet my friend Edward from Sickle from Stroke Association of Kenya. Our friend here, Eunice, from SCAT, and very many other organizations. And we met at the NCD Alliance of Kenya, which brings together now all the organizations which are fighting NCDs in the country towards the NCD Alliance of Kenya vision of an NCD-free Kenya. And I've been asked to speak to you about, she'd actually asked to come and speak about 3 things. One of them is patient safety, the other one is patient voice, and the third one will be the new health insurance arrangement that is coming up in the country. We have probably seen a bit of patient safety, but if I can just give a background, what is patient safety? Anyone?
For example, a facility to seek for medication, how they should be treated in a safe manner. Yeah, that is how I perceive the word patient safety.
Okay, I've seen another hand. Are you too? Patient safety. It's simply the prevention of adverse effects and errors in a healthcare setting. You realize when you go to a hospital, and there are so many of you, there's potential for a lot of things to go wrong in that process. And I'm sure you have all heard horror stories. I think the most horrendous was the one where they did the head surgery for the wrong patient. That was sobering. You are like, but why did that happen? First of all, that it was alleged that patient answered to the wrong name. When they called out, he said, "Yeah, I'm here," so was doing that. So if you're in hospital and you're waiting for a procedure, please confirm your name. You should confirm, make sure. Did you call? My name is John. Did you call John? You call me? It's there. Hospital number?
Have similar names. For example, where there's an instance where there's minor karanja. So like 3 of them are called the same name.
Yes.
So you need to go like for the third name so that at least you know which minor karanja are we talking about.
Yes, but if you're in the same hospital, you have different numbers. You may have similar names, but you have different numbers. And minor karanja is not a problem. There are places where you have people called Mohammed and Patel. Do you know how many millions of Patels there are? There is more than 1 billion Patels. So in a hospital, you will find, and they live in the same zone. So you will find a hospital where everybody is a Patel, from the doctor to the cleaner. So verification, yeah? Show your documents, show your ID, show your everything, so that you are sure that it is the right person who is being treated. And you don't have that confusion of names. And confusion of names is just one way of being given the wrong treatment, which does not belong to you. Now, the World Patient Safety Day came as a result of a resolution by the World Health Assembly in 2019. That was resolution number 6 of Assembly number 72. It was in 2019, and came out of the recognition for the need to start engagements that would make sure that patients are safe. And I will give you some of the facts here that the occurrence of adverse events due to unsafe care is likely one of the 10 leading causes of death and disability in the world. So it's a big crisis. And usually people think it's only in Africa or Kenya where these things happen. It's a worldwide problem, because it is very, very easy to confuse things and give someone the wrong treatment. Now, each year, about 134 million adverse events occur in hospitals in low and middle income countries. Hii mnakuwa gani? No, low mid. Ai, hapana. Mulipanda. Middle. We are middle. Which is good and bad. It is good because it means mumeendelea kidogo. It is bad because there is a lot of UN related assistance that you cannot receive because you are not low. But si afadhali mtu akulie mahali yake. You don't want to remain low so that you can receive donations. Hata tupande, hata tuwezekana tufike high. When you attend some of the international conferences, including online, and you people from Nigeria, Cameroon, wherever, and I remember I was complaining that in Kenya we only have 2 sessions of dialysis, and the national recommendation is 3 sessions. Nigerians were screaming, you are complaining that you have 2 sessions. We don't have. we don't know what you're talking about. We would wish to get where you are. So Kenya tunakuanga mbele kiasi fulani. So it's good to be in the middle, and God willing, go to the highest level possible. So 134 million adverse events occur in hospitals, and these result in 2.6 million deaths. So it's a big crisis. It's unacceptable, and globally, as many as 4 in 10 patients are harmed in primary and outpatient healthcare, and up to 80% of harm is preventable. Again, that's why we need this campaign, because most of the things, 80% of the things that cause harm in the healthcare setting can be prevented. So we need to invest in reducing patient harm, which will lead to significant financial saving and, more importantly, better patient outcomes. And an example of prevention is engaging patients, and if done well, it can reduce burden harm by up to 15%. Just engaging patients, letting a patient know what procedure we are going to do, how it will look like, and what it will do to you. Unfortunately, and I'm very sad to say this, a lot of patients, including from my organization, somebody has done dialysis even for 5 years, but they are spectators. anaendaga tu hapo analala, anafanya kazi, anabaki. Hajui ni nini yaendelea. You should be curious, you should ask. It reminds me when I was in primary school, and I would wake up in the morning, I'm preparing to go to school, then my mother would wake up and say, "Hey, Wendy." I'm like, I'm told, remove the uniform, and the next thing I know, we are in Kanyanyaina dispensary, and she's telling a story which I am completely a stranger. Ati silali, sikuli, nakohoa. Mimi. Ati nina joto usiku. I have no idea. That time I was a child. I cannot afford to be like that now, because I know I'm living with a condition. So it is up to me to educate myself about that condition. And that works now to the patient voice that we shall talk about below here.
Just a question. I would say, in our national government hospital, Kenyatta, when you go there and they find you reading that file, it is your file, and they find you reading that file, and they ask you, mbona unasoma your file? Kwa nini? What will you answer? Because that question I've been asked so many times.
Okay.
Because I need to know what is going on with myself. And the doctor wrote some notes the previous time, and he did not even explain to me what he's writing down. So when I come back the next visit, I want to know what he wrote down. Then they ask me, mbona unasoma your file? I'm like, am I not supposed to read the file, or is this information kept for the doctors take care of, or how would you answer such a question?
Okay, I have been asked that question at KNA. How do you think it went down from that day? So the first question was, which file? So they say that file. So I read, whose file? It's my file. Yeah? All that information is my information. All the tests, results written there, I have paid for them. So how is it not my file? Don't accept to be bullied by people who are still living in the past. The only file you cannot read because of information and data protection is another person's file. But your file, you have the right to look at it. Number two, if you need copies of some tests you have done that are there, they should be given to you. They are yours. You paid for them. Yes, but sometimes to avoid all that altercation, whenever you do tests, take 2 copies. Keep your set, keep your file, and let the hospital keep its file.
But sometimes, most of the time, like when you do the test in the hospital, they don't give you the result.
Demand a copy. Demand. Now, let me tell you one thing patients don't take advantage of, and not everybody else can do this. A patient is the only person who is allowed to roll in the dust and scream. You are a patient.
I thought we were talking about the patient safety.
Yes, but you are in pain. So, if things are not working your way, be the patient. Yes, be the patient. Don't agree to be bullied by the system. You are a patient. You should be. And there is a reason why we protest hospitals calling us customers. Because I have had also an issue with KNH. It's trying to describe us as customers. We are not customers. The word patient has a special connotation. Yeah? Which means that you are someone who is living with something or who is suffering from something, and you need to be handled with care, compassion, and all this. You are not like mtu anduzi mwenye ameleta kitu amedeliver hapo anangojea majibu. No, you are a patient. So don't allow to be bullied by the system, and you should work with your healthcare provider for patient engagement and patient involvement. You will find that most of your support groups that we have now, most of them start in the hospital. Yeah, in the clinics where you go for care. And that part of the care, helping you to come up in a support group, because They know beyond the care they give you, there is peer support that you can give one another. Remember, all the care you get in hospital, in most cases, you pay for it. So you only go when you have money. But where else can you go for support, even when you don't have money, even when you are not near the hospital? It's in your groups. Yeah? And if your hospital is already empowering you to get into a group where you can talk about your issues, I don't see why they should be so rigid into cooperating with you and treating you with compassion and teaching you about your condition and how you should care for yourself when they are not. Remember what I said about doctors. But they are also heavily invested in the outcomes of the diseases that they treat. If you are a doctor and people you are seeing are dropping dead, you're going to be very worried. Yeah? I remember when I got my kidney transplant and I regained consciousness, I saw doctors jumping, the nurses and clapping and hugging, and I'm wondering what happened. It was actually kidney had made urine, and they were so happy, and they did not know that I was seeing them. Yeah, but this is something they have worked on together as a team, and it has worked. So doctors are not just, you see them passing around, they are heavily invested in the outcomes of the work that they do. They want us to get well. That's what makes them sleep better at night, when they treat us and we get well. So if you engage them properly, you will be able to work along with. They will walk with you the journey. Outside, try and meet them outside the clinic. I usually do not miss walks. If the sickle cell walk or a walk, World Kidney Day, I'll be there. I go for diabetes walk and I don't even have diabetes. Why? Because there I can walk with Dr. Jenga for 10 kilometers. I'll never have that time anywhere else. Yeah. You understand? So go for these things. Engage with them. Talk with them. When you do that, you create now an atmosphere whereby there is that trust in you. You are able now to talk, even things you're not able to see in a clinical setting, where we may have what is called white coat effect. Boy, kwenda ukiumwa na meno, ukifika pale unashindwa ni gani. Na hujalala usiku mzima, but when you get to the dentist, karibuni sana. Tumejifunza kuhusiana na usalama wa wagonjwa katika mazingira ya hospitali na huduma ya afya. So we have said that patient engagement can help reduce adverse effects by up to 15%. Why does patient harm occur? There are very many reasons and types of patient harm that can occur in the hospital. I've told you how many people get affected by patient harm, how many people die. Now, I'll just take you through some types of patient harm. One of them is medication error. Medication error, which is the leading cause of injury and avoidable harm in healthcare sector. Globally, the cost associated with medication errors has been estimated as $42 billion annually. Hasara ile inatokana na mtu kupewa ile dawa ambayo sio ile alistahili. Then we have what is called healthcare associated infection. You all know the healthcare infections, the ones you are likely to get if you are admitted to hospital for a very long time. The ones that make them say children below 12 years cannot use it at home, so there is likelihood of taking something. There are instances where you will be admitted for one problem, then you will go and fix something else in hospital. So that is a form of patient harm. Unsafe surgical care procedure, I think that one we have talked about. The case of the person who got the wrong surgery of the head, and he was not the patient who was supposed to get that Then we have unsafe injection practices where you are given the wrong injection or it's not done properly. And then there is diagnostic errors, which now causes the theme of this year's World Patient Safety Day, where there is misdiagnosis of the condition that you are living with. And like I was explaining when Eunice was talking, you can be, if you are living with a condition like we do, there are two forms of misdiagnosis that can happen. And we said, for example, usually when you show up with a case of sickle cell, the first misdiagnosis is malaria. Then we said, but you could actually be having malaria, and the doctor is thinking this is the kawaida sickle cell. So those are things that we need to look out for, both patient and the healthcare worker. And like I said, diagnostic errors are very, very rampant in the world. It's not just in Kenya and in Africa, it is in the world. And because healthcare has become a bit complex, and also most diseases present the same. Now, whenever you go to hospital, what is the first thing you do? Fika pale hospitali umepewa namba ama umeregister. What is your next station? It's like a place called trial. Where do you check? What do they check? Pressure, temperature, height, oxygen. Now, almost any disease will cause your temperature to rise. If you're fighting an infection, the temperature is going to be high. Yeah? It may affect your BP. Sometimes they even go forward and take your blood sugar and urinalysis. There are very, very many diseases that present around. Now, there's a saying that says that if all you have is a hammer, every problem looks like a what? Huh? Like a nail. If all you have is a hammer, you're holding a hammer. Kila kitu. You see a noisemaker there, you want to hammer that. You want to hammer it. So, the same with doctors. And I'll give you an example of, a living example of myself. I attend a renal clinic. And every time I have a problem, that is where I inform. Because my first concern for my health is about my transplanted kidney. Now, whenever I present at the renal unit, they will take my urinalysis and they will take my UECs. And if those are okay, there is so much relief that I am not sick. So if I insist, the only other thing that can affect, that can come as a result of your condition is if your medication has caused you other infections, the most severe, which can be TB. So they will check, do you have TB? No. Do you have this? Do you have another infection? If they find that their kidney is fine and I do not have any opportunistic infection, they are relaxed. You get? They are relaxed. But unless I insist that no, it's beyond that, it's like this, that's when now they will refer me to another place. But tukienda tupime tuone hizo vitu zote ziko sawa, hata mimi ile uchungu nilikuwa nayo reduce, narudi nyumbani na ugonjwa. Sawa sawa. On the other hand, whenever I present to a healthcare facility, which is not a renal unit, the first thing I announce is that I am a transplant patient. You say, I'm a sickle cell patient. Even though you come with a headache. And I remember saying that with a dentist. And he was doing a root canal treatment. And he said, okay, if you are a transplant patient, that means you have lowered immunity, which means you have a higher potential for getting an infection from the procedure I'm about to do, so I'm going to put you on antibiotics. Understand? So this conversation must happen. And we are all doing this to avoid an adverse effect from the procedure that brought me here. Not related to my condition, but it can escalate because of the nature of my condition. Kwa pamoja. So it's very important to pick up. Unajiongea kama Mkristo vile unatoaga ushuhuda kila mahali unaenda. Yeah? You must explain. Every health care worker who handles you tell them. Dialysis patients who have a fistula here, they have to tell anybody, do not put the blood pressure whatever here, because it's going to interfere with the fistula. And sometimes you may find healthcare workers who resist. You insist, no, you cannot put it there. So it's up to you to speak for yourself. It's up to you to say what you live with, even when you're in a setting where there doesn't seem to be any relationship with that. Then we have unsafe transfusion practices. And unsafe transfusion practices is the potential to give you something you didn't have. Unsafe blood can give you hepatitis B, it can give you HIV, etc. In dialysis settings, in dialysis units, we have a specific machine which dialyzes hepatitis B patients. Because if you use that machine, if you dialyze him with the other common machine, that hepatitis B is going to go around to all the other patients. So there are specific machines. During COVID, now they have to set aside COVID machines for patients with COVID so that again it doesn't get to other patients.
But they insisted that they want universal donor blood, which I tend to react with. But some doctors don't take that seriously. So how do you go about telling them about that? Because we really had an argument. We really had an argument that you can receive the
So you're saying you react to that?
Yeah, I react to that.
Do you have a doctor who knows that?
Yes.
That's the doctor you tell them, do not put this in me until you have spoken to Dr. Swed. Or you call him yourself. You explain to them that he cannot be put on that for 1, 2, 3 reasons. Yeah?
Yeah.
Remember the walk with the doctor on World Sickle Cell Day? Yes, get their number. Come their friends. So that if you are in a situation, you can text him quickly or call him and he'll be able to respond and say, don't do that to him. Yeah? Yeah. But first thing is to refuse.
Yes.
Now, as a patient, you have the right to refuse. You can say, yes, mimi mgonjwa lakini haki hiyo matibabu.
But they still wanted to charge me because they just admitted me.
Are you in a private hospital?
Yeah, it was a private hospital.
How did I know? Yeah.
Yes.
Yeah. But you refuse. And you refuse to pay. You can't do nothing. Unakataa.
Now, did you refuse?
Transfused. Yeah, okay, at first they lied because we said we wanted the exact blood. We had not found it in another hospital. So we came to this hospital and they lied. Instead of telling us we don't have the B positive, they waited for my mom to go get something so that they can start transfusing me. But when they wanted to start transfusing me, I had to confirm, is this really the correct blood? Then I found it was the universal one. Yeah. Then I refused. So they started saying that we have to charge you because we have already admitted you. But we had to leave that hospital at night.
The first thing is to refuse. You refuse. And no one can force you to take treatment. Yeah? Now, however, if it is an emergency situation and you need emergency blood transfusion, and the blood that is there is that one that you react. And they will weigh the risk. If we don't transfuse you, we lose you. So we will transfuse you with the one that reacts, then we will deal with the reaction. Yeah? So we also can't be so rigid. We don't do this, you can't do it. No. If it's an emergency situation and you must have that blood, probably you won't even be in that conversation if it is an emergency. Then there is always the balance. Because not all medical procedures or treatments are safe. The medication I take for lowering my immunity are also harmful to the kidney. Yeah? They lower my immunity, so I'm likely to get other diseases. But now we balance. You must strike a balance that we can make some good and it will sustain his kidney, and then we keep it at a level whereby it is not too high to reject the kidney and not too low to allow other infections to come in.
Yes.
So we see him every 3 months and we look at it and adjust accordingly. So sometimes, healthcare workers have to make those decisions on our behalf because they are looking for the best outcome. Okay? So we have the right to refuse treatment and we should reject anything we think is unsafe, but also do not block treatment by being too rigid and saying mapambano in hospital. No. We also must strike a balance. Okay?
Yeah.
Yeah. So radiation errors can also happen in hospitals. Sepsis, venous thromboembolism or blood clots. And I'm just giving you examples of things that can happen in a hospital. But patient safety or patient harm is not only in hospital, it's not just related to the medical practices. You can also get other harm. You can be stolen from hospital or abducted. Yeah? Yes. You've not had cases where KNH has lost the patient. You left your person, he was admitted, then you come the following day, he's not there. Nobody knows where he is, and the CCTV that is hanging there was not working. Yeah? You can fall on a wet floor and break something in hospital. That's still harm, not now healthcare related, but still in hospital setting. I have a third instance where one of our members committed suicide in KNH last year. Very sad situation. Yeah. It happened. Yeah. And the doctors were so devastated because he had just been admitted from Nyeri and he was supposed now to be taken through triage and all the things. Then the doctors were seeing the following week. But that night he killed himself. And the doctors did not even give him a chance to attend to him. He had received a transplant which had gone wrong somehow. So he had now come to KNH for correction surgery. He didn't wait for it. Yeah. So these things happen. No.
Okay.
I will tell you a story about coming late.
Daktari ama mwalimu. Now he mentioned a very important case like the blood, reacting. Because these are cases where anytime, most likely if they get admitted, there's instance of transfusion. How do they handle like that reaction to the blood?
First of all, it shouldn't happen because every time I am admitted to hospital, I am asked questions to the effect, do I react to anything? Do you react to any medication or treatment? So if I am asked and I have said I react adversely to universal blood, then that should be on record. And the reason I asked whether it was a private hospital is because when somebody is insisting on a procedure that they have been told should not be happening, might have adverse effects, might cause harm, then there are other considerations at play, usually commercial. Yeah? So it shouldn't happen. If a patient has said, I react adversely to this, don't do it. Before you came, you were saying we should be walking around with cards or banners, police banners, which say, I am this kind of a patient, I am on this medication, I am react adversely, 1, 2, 3, 4. Or in the name of preventing being given the wrong treatment. So in the first instance, it shouldn't happen. If it's an emergency situation, like I said, and it's the only blood, and they are aware that adverse reaction will happen, they cannot proceed unless they have decided how they will deal with it.
And that's because there's a time my daughter reacted for transfusion and they had to stop.
But they didn't know. Probably that's the first time it happened. Yeah. Because you would not have allowed it. And if you knew your daughter reacts to this blood, you would have been there making sure it's not the one. Like he said, he knew he reacts to universal blood. So he said, don't give it to me. But there's always the first time that it happens, and that's when it is known, oops, couldn't give this. I want to move quickly, and I think I have covered most of the things to do with patient safety. There is also patient safety at home. Yeah. First harm you can bring to yourself is to deciding leo sikunywi madawa tumekunywa miaka mingi hata haidiki. Over the counter medication, drugs that you have not been prescribed. Your uncle from Narok who came with a concussion, alisikia wewe huo unasumbuliwa na sickle cell, amekuja na vibuyu viwili vya dawa. Don't. Naosha tumbo. Unaosha damu aje? We have some foreign language that excites me. There's a Maasai I see walking around my estate. And what worries me is not even the concussion. Is that he only has 1 cup. 1 cup. Yep. Not to taste. He sells you. Usually he amused me at dawa zimepanda. Least amekansa ile bei ya zamani sasa. I usually chat demand when I meet him. Yeah? Yeah, dawa zimepanda. Na kikombe ni na hana maji. Wewe ukilipa unawekea. Watu wanakunywa. I was sitting in a bus. Those of you who go to KNH buses always have snake oil merchants who come to sell you things. So there was this guy who was selling a bottle like this, which is a cure for all. Cure for everything. 2 drops in your tea, kama ni mtoto 1 drop. So the guy who was sitting next to me, he bought. Then I think he forgot the dosage for the child. So he said, Daktari, I wanted to punch him in the nose. I told him, excuse me, this is a hooker, not a doctor. I was like, oh. He has a white coat and everything. So he called him and he asked him, atumesema mtoto ni ngapi? I told him, please, don't do experiments from hawkers with your children. And the only reason I'm speaking up is because there's a child involved. Don't give your children. Wewe ende ukunywe. Ukitaka drop 10, mtoto wachana wewe. Yeah? So don't take things. Usually the people who come with these concussions are well meaning. Yeah? Amesikia uligonjeka, ameambiwa hiyo inatibu, they will bring it to you. These things will do more harm than good. Sawa.
So what would you how would you tell someone that what you have brought, I won't take it? in a polite way. Because they've carried that bottle of that concoction from all the way from Uganda and brought to you and tell you that
Okay.
Just
thank you very much. Unachukua akitoka kwa sink. Simple. Because
Wewe unakubali tu.
let's not sugarcoat. I think I've reached a point where we should stop sugarcoating these things.
Yeah.
You know-
Okay, let me demonstrate. Where is the cigarette?
okay.
You will notice that I have not drunk her juice. Who had noticed? I didn't drink the juice. The reason I did not take the juice because it is uncooked. So it's homemade juice, it's mixture of things, yeah? It is uncooked. Now, I'm not allowed to take uncooked things because of my lowered immunity. Yeah. Now, I may not be able to explain that to everyone. So sometimes I may seem rude and everything. But if it's somebody I can talk one-to-one, I can talk, thank you very much, I cannot take this because it's uncooked and it may have things that cannot affect other people, but in my instance,
You just don't take.
yeah. Rahisi. People do. But it is up to you to know the things that can bring you harm. Which now introduces the patient sometimes we refuse to take things.
It's a choice.
Yeah, it's a choice. You say weka hapo nakunywa. Yeah, sio saa hizi. Ama madawa na kunywaga jioni. Yeah. And what are you doing now? You're speaking for yourself. So we are now on the subject of patient voice. Now, speaking of patient voice in relation to preventing harm, it is up to you to speak up. And he has given a very good example. Something is going down, you know it's going to harm you, you say, hello? Nope. You cannot do that. If a procedure feels painful, painful than you are expecting. Hata kuna suru unadungwa sindano. Kuna sindano unaweza ndungu usikie, ai, hawa kanya hawe. You will say, no. That's not normal. So it's up to you to speak up. You have the right to refuse treatment. For whatever reason. You can say, yes, I have cancer, but I'm not going to do chemotherapy. I've decided I will not do that procedure. I have kidney failure, but dialysis, if I give care. When you refuse treatment, you should still receive palliative care. Care to make you as comfortable as possible to live with your condition until your time comes. So you should not be abandoned. Ati wewe umesema utaki toka hapo. No. You should now be put on palliative as comfortable as possible. Like I said earlier, be alert. Whenever you are in a hospital setting, don't respond to somebody else's name. Compare your documents. I have seen at KNH, I don't know how many of you have been Pharmacy 40. Pharmacy 40, what is the procedure for treatment? For getting madawa? Unaenda, kwanza mnaweka nini kwa kabox kamoja hapo. Hata ile pharmacy nyingine 15 ile iko pale kwa entrance. Mnaweka makaratasi yenu hapo. Alafu mnaitwa watu watatu. Mnapewa hivi. Nishapewa nini? Prescription sio yangu. So I'm reading. No, this is not mine. I thought, leta hiyo. Nani? Later you. Then they get the person who has mine. So those confusions are likely to happen. So if you are not alert, if you are not careful, I've even bought drugs and I didn't get all of them because I didn't check to confirm ya kwamba zote ziko. So be alert, confirm again with every procedure, every treatment that you're being given. Make sure the file is yours. That is why you should read it. Yeah. So be alert. And it is very difficult to speak up for yourself, especially on policy matters, alone. And even as a patient group, it becomes a bit difficult to speak up now as Renal Patient Society. And we want to speak about dialysis and transplant and the drugs. That is why we have joined the NCD Alliance of Kenya. because now NCD Alliance of Kenya is a bigger body which brings more people together, and it has a more amplified voice. From when I joined the NCD Alliance of Kenya, I have been able to go to the CS's office. What was the CS? The only CS I didn't see was Sickle Kariuki. Leona CS alikuwa anaitwa Tai Kagwe. What do you want to? But when you now go with a bigger organization, you are hiding behind. That time I was not even in the board. You're hiding behind NCD Alliance of Kenya, or you are inside. Then you go, you climb higher ladders, you go to other places. So it is good to organize ourselves in patient groups where we speak up for ourselves in the health facilities where we are being treated. And from there, we joined other organizations, both local, national, international, so that we can work together with other patients, get to know other forms of treatment and management of our condition that we may not do, for example, and also be able to give feedback to the people who take care for us. We tell them what is working, what is not working, what we want, and what we don't want. That's how. Yeah, so we should always try to put ourselves in advocacy groups, and so that we are able to petition decision makers. I don't know if the sickle cell doctors usually have a conference. They have a conference. Yeah. For your personnel, health personnel, hematological.
Yeah.
Yeah, so those are some of the forums you should make sure that you're presenting. For kidney, we have Kenya Renal Association Conference, which happens every year in Mombasa in October. And for example, the idea we were saying of a QR code, that is where you will take the message that sisi kama sickle cell patients, we have come up with this QR code which will have all our information. So if you find me unconscious, just scan this with your phone and you will have all the information. You will have killed so many birds with the nose scope because you went to the forum where they meet and you talk to them. No, not Maisha number.
Let me say, like now, what you have just said, that there's something going on in Pakistan. Such informations, it's very hard for us to get such information, but they're usually kept for the doctors. So most of the meetings...
He's just challenging.
I'm challenging you now. There's something called nose in.
Okay.
Have your nose in all those places. Yeah. And I can tell you the first time you will not be welcome.
Yeah.
When I went to the first Kenya Renal Association forum, there were even protests. What is a patient doing in a doctor's meeting?
Yeah.
I've also heard those dissenting voices.
Yes.
Anytime patients speak from a patient point of view,
then I missed.
They look at you like.
I missed one conference and I had 100 calls. Where are you? Why aren't you here?
You're the voice.
Yes.
Yeah.
And that time it had just been announced that the ministry was NHIF was dropping one session. No, not one session. Was dropping the cost. The money they were paying from 9,000 to 6,000. Now that's where they need someone to do what I said. Out of the ground. Yeah. So they were looking for me. But I told them, okay, I couldn't come back. When you come back to Nairobi, we'll pick on it and we'll work on it together. There are some lengths your doctors cannot go. And I remember one of my doctors, when I became a patient, I used to ask him, how come no one is saying about it? How come not? So he asked me, because can you imagine me with a placard on the road asking for a third session of dialysis? I would look awkward because I am the one who gives the dialysis, not the one who receives it. That is your job. It is up to you to go and ask for it. I'll give you the information on why you need this and why 2 is not sufficient. You take it, you go to the road. That's how. So make yourself informed. Know about anything happening in your sphere. not just in Kenya, in the world. Sawa. So
That's what you'll never know, and you'll never get an invoice very soon
Yeah.
because it's a doctor. So it's you to say, how can
and
I
it's not just I've been to NHIF forums where I was not invited. But since I'm there, I cannot give no. And they try to close me, and excuse me, and we are there with the media and everything. So they have to allow you to speak. Nimekuja to say, my name is Vikonyo, and I came here to say 1, 2. That's how I met Mutai Kago the first time. Anyway, I have 5 minutes to go, and I need to talk to you about the new health insurance scheme that is coming up under the Kenya Kwanza government. That is, okay, what do you guys call it? Because it has so many names. Chief, yeah. Chief. Okay. Let's start from the beginning. There's something called beta. What is beta? Beta. You see what you did? Okay, you know now if you look throughout this country and look for one person who voted Waruto. Huwezi pata ama upate mtu wa UDA kana sio mimi. Wewe uliniona. So beta is the, remember a party comes with a manifesto. So beta was the Kenya Kwanza manifesto. It's called Bottom Up Transformation Agenda. Bottom Up Economic Transformation Agenda. Bita. Hiyo ndio ile inatumika kufanya ile mikakati yote inafanywa na serikali ya UDA. Katika hiyo bottom up, hiyo bita kuna affordable housing ile mnaitajaga wasi 1.9. Kuna food security ile tunatoa alaiza ya mali ya food. Kuna UHC, Universal Health Coverage. It's in there. And now I'm at UHC. Now, UHC will be realized through some changes that were done last year, where we got the Digital Health Act, which I talked about earlier. Then we had the Social Health Insurance Fund Act. And then we had Facility Improvement Fund Act. And I think, if I'm not wrong, Primary Healthcare Act. So those 3 acts are the ones that the government hopes to use to propel UHC agenda. If you take now one, SHIFA, Social Health Insurance Fund Act, ikatupea kitu inaitwa Social Health Authority. Yeah? Ile zama mnaita SHA. Hiyo SHA ndio imereplace NHIF as we know. Ndani ya SHA kuna SHIF, Social Health Insurance Fund, kuna Primary Healthcare Fund, na kuna Emergency, Chronic and Critical Illness Fund. Fund gapi? So NHIF now has been expanded to 3 funds. Those 3 funds, SHIF wewe ndio utalipa kila mwezi. The other 2, PHC Fund and ECCIF, unalipwa na nani? Na serikali. Unalipwa na serikali. Serikali ndio itakuwa inapeana pesa from the budget, nasema hii inaenda kwa ECCIF, inaenda kwa PHC. Wewe unajilipia SHIF. It is mandatory to register with SHA. Because hata kama hulipi SHIF, hizi zingine mbili ni your tax. So you should be able to get treatment from there. But kama hulipi SHIF, utapata benefits ya SHIF. Kwa pamoja. SHIF unalipa 2.75% of your salary if you're employed, or of your what they call annual household income if you are not employed. How do they determine annual household income? It is through something called means testing instrument. So they ask you a few questions about where you live, how you live, and all that, and they are able to ascertain that this is the amount you earn per year, and from that they deduct 2.75%. It is something similar to if you have been following the University Education Fund, you have the 5 bands. Kuna band ya wale watu wako na pesa. Wale watu wako na pesa ni band 5. Band 5. Na kuna band ya wale hawana ambayo ni band 1 na wengine katikati. Now because you come from Kiambu County, and Kiambu is a very rich county, mara moja unawekwa band 5. Hata kama mnalala nje. Wewe ni Kiambu? Kiambu kuna pesa? Band 5. Hiyo mtu atasoma. So those are some of the risks of now, some of these ways of determining your level of income. But that is how it will be determined. There is a registration going on. It is supposed to take off officially from 1st of October. What is the hashtag for? Is it *147 hash? Yeah? *147 hash. Now, if you're living with a chronic condition, do not be caught dead without a cover. Because you know very well that there is a limit to where your funds can take you, and you will need a cover beyond that. We don't know how exactly this will pan out. As we speak, we are continuing payments for NHIF for continuation of our treatment, but you better err by being in than by being out. Let me give you an example. If you get kidney failure today and you need dialysis today, a dialysis session is 9,500. If you do not have the 9,500 and you do not have an NHIF cover, you are going to die. Because you cannot afford dialysis. Hakuna mtu atakufanyia dialysis ya huruma. Either you can pay for it or you cannot. And that is when a lot of people now start running to pay. And NHIF has been just $500 a month. Na mtu hajai lipa. Saa hiyo anataka kulipa 90,000 za miezi sijui ngapi. But hata ukilipa you have to wait for 3 months for it to mature. So it is always better to err on the side of caution. Register with SHA. Hata kama hutalipa, kwanza register. Ukue huko ndani. Ndio lolote likitokea, at least you can be sorted with ECCIF or PHC while you figure out how to pay the shit. But hata hiyo ikiwezekana, lipa. Always try to be on the safe side because your circumstances are different. Sasa, kwa pamoja. Watu waingie nini? Watu waingie SHA, SHIF, hiyo lote. And I think my 5 minutes are up. I will take a few questions, then we can hand over to next.
Ama tutalipa tu moja.
Mambo ya double imeisha. Okay, let me explain. If you are self-employed, once they determine your 2.5%, you will not pay it monthly like before. You will pay it once for the whole year. Yeah. So if you are assessed for 1,000 shillings a month, you will be asked to pay 12,000 at once. When I registered, they asked me to pay 20,000. I've never gone back to that section. That EOS. Yeah?
Yeah.
Now, then the next question you ask is, what if I don't have the 12,000? They are going to introduce what is called insurance premium financing. Watakuambia, enda kwa huyu, anakukopesha pesa, atakulipia hizo 12, wewe ukuwa ukimlipa kwa mwezi. So I've not yet seen any of those, but that is in the act. And I would invite all of you to read the chief documents. Read the SHA Act, then read the SHA regulations, then read the benefits package. Document that, and they are online, so that you understand all those things and you know where to put yourself. Have I answered your question?
Yes, you have.
Good. Another question? Okay. Now I can look for some water to drink. Thank you very much for being attentive, and I hope you have learned something from me. Na tuelimishane, ukijua kakitu najulisha mwingine. And some of these things, like the SHA things, much as we are saying they are critical for us because we may need treatment regularly, it applies to everyone. Anybody can get sick, and if that happens and you do not have health insurance, then you're going to have a very big problem. So encourage even your families and everyone else to register. Tujue ni mbaya ama ni nzuri ukiwa wapi? Ukiwa ndani. Ukiwa ndani. I usually say, if you find people discussing the menu of Muthaiga Golf Club, can you participate in that? If you are not a member, can you participate? You can't. You are not interested. Hata kama wanakula nini, you don't care. The same thing with NHIF or SHA. If you are not a member, whether it is good or bad, you are not involved because you are not a member. So become a member first. Piga makelele ukiwa ndani. Thank you.
Thanks, Mr. Kikoni. I know we've met before, but you don't remember.
I can remember very much. I can remember very well.
And Edwin along, I'm a pathologist. Many times we get pathologists to think of, and I'm actually just and the theme of this discussion is how the postmortem plays a role in patient safety and why you should be interested in it.
Are you seeing bodies?
You will see some bodies. Unfortunately, you have to see something. But I'm assuming that you're here because parental guidance is advised. Don't know if there are any parents in the room.
As long as the baby is still asleep.
The bodies are still. But anyway, what I'll do is I'll try and give some positive stories. So the reason I'm here, I perform autopsies for the purpose of disease surveillance. So my colleague Dr. Odwar is always on the media because someone has been shot and that. But mine is always to understand specific diseases. So why are people suffering from this and that? And the overall question we want to answer, how can we save similar lives? So we look at it as this individual who has died has donated their bodies to science. And why have they donated their body to science? To actually save lives. And we have several examples. So the good example I have here is on a disease process called immune deficiency, primary. What does it mean to have primary immune deficiency? We call you Daktari from now on. Few people are calling you Daktari. You want to weigh in on that term? Immune deficiency. Yes.
It's where your immunity is not optimal.
Right.
Not where
it's not exact, and you've alluded to it.
Yes. Now, mine is drug induced. I take drugs low and that it does not fight organ recovery, kidney recovery. Because that is what the immunity does.
Exactly.
It fights foreign objects.
Right. And now the story here is about individuals who are actually born with a failure of their body to develop an immune response. And so one day what was happening, I was in the autopsy room where I used to work, that is KNH, the postmortem room. And we said you do not want to see some things, I'll try to shade them out. So in this period of time, I was particularly interested in why children die. And children, these are deaths of under 5s. And we had a study where we were performing postmortems for that purpose. We did quite a number of postmortems. And there are certain cases that I came across. So this case was an infant. So this lady has a 4-month-old infant admitted. They've been referred from far. I think they had come in from Garissa, then moved into Muranga, then found themselves in KNH. The child unfortunately died and had a severe infection. We all know that children die of infections a lot, right? But what was unique about this case is that this lady had lost 2 other pregnancies, other children before. So this was a third child, no living child, dead at 4 months. And of course the first one died, then the second, of course, akasema ni ya Mungu, si ndio? Second child died. What did they now start saying? Yes. Unfortunately, they said that, and it was so that she was actually thrown out of where she used to stay and left the in-laws. But the husband was good and stuck by her side, which is very rare, isn't it? Why are you thinking very fast?
You know why?
You know why? Now this third one has died, and of course, the nurse is like, why don't you just have this investigated? Maybe there'll be answers that will do something. So they requested a post-mortem. So we went in and performed a post-mortem of this child. I know I'll show you some pictures later, but not of this. But one of the findings is that we found an explanation why. First of all, we found something that was unusual. There's a structure called the thymus that's usually in the chest. And that's where immune cells go to mature before they go to the rest of the body. In addition to that, this is a picture of the pathology of the brain. So for us, we diagnose disease through a technique called histology. So histology is that we've taken tissue, taken it through some processes so we can examine under the microscope. And when we examine under the microscope, we can see that there's an infection. This is was fungi. So for that to occur, there has to be something. So we saw the fungus, we tested for other infections, we found many infections in this child that we should not be seeing. So we had a question, is this an immune deficiency? We really did not know how to diagnose them then. So we sat together as a scientific team. There's a family history, and she doesn't have a certain organ that did not develop. What this is, I won't take you through, but we somehow ended up somewhere. Which one did we end up in? I think it's this one where I have a lot of text there. So we decided to do additional tests on the tissue, and this is the spleen of that particular child. And here we are looking at for the cells that fight infection. And the cells that fight infection, the so-called T lymphocytes, were not there. And it is a comparison of the spleen of a child who had died from a road accident of the same age, acting as a control. So we established that this child does not have the cells required to launch an immune response. We sat together, came up, and we decided the actual diagnosis. Anyway, the story for this couple ended up having an interesting twist, because we realized that this is a genetic disease based on the presentation. We didn't do genetic tests, but we could look at the patterns, and we realized that one of the parents is probably carrying this gene. We could see that the parent, who, based on the physical characteristics, was carrying the gene was the father. What did you say? Unfortunately. So we wrote this report and we said, you're a good couple. It's about measurement of the distance between the eyes. It's a facial characteristic. I know now you'll start measuring everybody. That is why if you are dating a doctor, they always look at certain things. Those of you who've been there know that. Anyway, the story ended up very well. I wrote a report and I told this lady, please go to this gynecologist before you consider having the next child. And I knew which gynecologist she needs to go to. One of these senior gynecologists who know how to handle this situation. Anyway, good story that they called me a year later and said, we were successful this time. we have a good child now. We are happy. We don't know what they did, but we are happy. Anyway, so this story, what happened, about 3 years later, we published this in a scientific journal, and we forgot about it. But about 3 years later, I get an email from this institution, the International Patient Organization for Primary Immunodeficiencies. And they were looking for, because when you look at African literature, nobody is identifying these diseases. So we have the first report. So they reached out to me, wrote an email and said, yes, we do this. We are an advocacy group. It's international. We would like to. So of course I engaged them, and at around the same time, I had another case. Now this case was referred to me. Now this was a different case now from Nairobi Hospital. Mother has had a child. The first child has certain infections that don't make sense. The pediatricians are trying to treat is not making sense as well. Positive in this newborn child, and unfortunately the child dies. Of course, Dr. Duor goes in and performs a postmortem and takes specimens. But then the question was, is there any pathologist who can diagnose this? And somehow they consulted, and I got a call from the mother. Actually, the mother is the one who brought those specimens to me in a container. And these are the specimens of my child. I need you to examine them. Anyway, we examined and we found this unusual infection. So this is again the histology test. And this is the thymus for that. So this time we found the thymus. But where the thymus was, there was this infection. All these pink things are bacteria. And the question is, why are we seeing bacteria here? And it doesn't make sense. And what bacteria are they? The way they're staining, they look like TB, but it's not TB. So
they didn't find it strange that the newborn baby is having TB.
Exactly. Sometimes it's a strange thing. Yes. A very healthy mother. Actually, she was quite young. She was 32. But she was very well read. I think she's a lawyer. Maybe you've interacted with her in your patient advocacy group. She will one day tell her story. Yes. She's a lawyer.
You have captured
She really wanted to know?
Yeah.
Sure. Yes. Wasn't buying it. So anyway, we established that this is actually an infection by a bacteria called BCG. Have you ever come across BCG? Do you people have a marks here?
Yes.
Do you have? So what is BCG? You don't have it. You're Ugandan.
You don't have it.
No, that's Ugandan, Somali dudes. Somehow in East Africa you can know who's who based on where the BCG sky is. So why is this in? Why is it, how does this? What's the reason for this injection at birth? I know you people are very informed. You always ask. But they actually inject a live pathogen which resembles TB, but it's not TB, because they want your body's immune system to recognize it in a manner that will prevent you from getting TB. Something like that. To sensitize your body. But since we don't have very reliable vaccines for TB, we get science has identified that we can get this bacteria, which is actually TB from a cow, right?
Oh, really?
That has been taken through certain culture processes that make it, in a way, it's not as infectious as the TB we are used to. So that if it's injected here, it causes this reaction, and this reaction is your body's immune system identifying that it's this, and it kills all this bacteria. And when it kills the bacteria, it gives you some immunity against TB. That's what it does, right? That's why you all get it. But now this child has absolutely no immunity whatsoever. And we realize that the kind of immune deficiency is a lot more complex. It's at another higher level compared to the one I discussed earlier, in a way that the body forms no defenses against this infection. So just have very minimal defenses. So this bacteria now multiplies and becomes an invasive infection. So that is what it becomes. Anyway, so this mother was informed, and she sat with me in my university office those days. You know how university offices look like? Just universities don't treat their people very well. but anyway, she came in, you know, she's a big shot lawyer. She's sitting in a certain corner, and we're discussing this. I'm showing her this picture, and then we realize, yes, there's an immune deficiency. Then she provided her family history, and we realized that, oh, this one follows the maternal lineage. The mother lost boys, so all the boys, the girls are the ones who survived, not the boys. So it happened that way. So that is called X-linked, right? So we know that it's something that is transmitted through the X chromosome without even having to test. Anyway, so what did this do? So I introduced that lady to IPOPI, and she became a strong advocate for immune deficiencies, to the point that now she's the one who follows up and does a lot of advocacy regarding the use of something called intravenous immunoglobulin, which is needed to provide at least some immunity to her own child. So she got pregnant, she got another child. At this point, we say that because of our experience, we expect that the same condition will be here because he's a boy. So for you, no BCG, no live vaccines, right? And you inject immunoglobulins regularly. And that boy is growing very well now. So that's another success story.
So then right now they don't have that mark.
So they won't have that mark. But again, this eventually we realized that there was a gap, and a group of doctors took it up, a certain group of pediatricians, and they started a specific clinic for this in Gertrude. They linked up with IPOP as well. One of my colleagues, who's a pathologist and an immunologist, became the champion for this and is now part of the Africa-wide advocacy group. There'll be a conference next year in Mombasa. I've been invited at least for one. Yes, or acid. Africa Society for Immunodeficiency Disorders.
Is he getting the job throughout life or
He will have to get it throughout his life. And they're expensive. IVIGs are expensive. But he will have to get it throughout his life. But at least he will live. So those are the success stories from the post-mortem. So a post-mortem is should not just be, I know many people will resist it. But that person who has died is actually donating their body for science in a manner that... Now I have other stories that are not so nice. So I have the next story. Are you ready for difficult images? Yes. Okay, now this is pediatric death. So what kind of when we looked at the pediatric deaths, we saw certain things. Now, this is a dead child, very severely malnourished, right? But what was causing this malnourished was very interesting. When we looked at the intestine of this child, we found a certain organism called Leishmania. Leishmania is common in arid and semi-arid areas, a parasitic infection, and strangely this one was growing along the whole intestinal tract. So these deaths are very complex in a way. To investigate them, we need to do a lot of work to really get to the bottom of this and characterize them properly in a manner that will make sense in a policy direction. This is a timer. What is on the right, and unfortunately I've blown up this picture a bit. What was I thinking? I must have been making this presentation in the middle of the night. The normal timers is what's on the right. Timers again is that structure in the chest where the T cells develop. The timers from that child who's severely malnourished is the one on the left, the tiny one, the one that's a strip. And we realize that there are certain environmental conditions that will make a child not have a good thymus deficiency. And in this series, we had many children come. It seems in that environment, people don't really get exposed to the sun, right? I don't know why.
Leave it flat. Next one, another.
At least you've started looking at the cause of first. In these children, okay, so again, I told you I'll show you a lot of things. So these are the lungs, and this was a pneumonia study. Pneumonia means that the infection is in the lungs, as you can see here. The thymus is usually somewhere here, we've removed it. And the typical, so one of the study is that the pediatricians have attended in your talk that if you have a mallet, right, something like that. So the pediatrician's hammer is a document called the Basic Pediatric Protocol that says a child with pneumonia is treated like this. What if that pneumonia is not that, and it will respond to that? So we've brought in a new level of thinking that a pediatrician should think beyond that hammer. Because we did lots of work, and in this, for example, in this picture, I'm showing multiple infections. In this child, we found an infection here called, who's ever heard of an infection called PCT? Pneumocystis. So they were trying to treat for pneumonia that's likely bacterial, but this that will definitely not respond to proper antibiotics. And you can see this fungus over here, a big fungus. Right, so why am I saying, and this is my last slide, so I'll conclude. So as patient support groups, should you be interested in the post-mortem? That's one question I have for you. The other, what other opportunities do we have? So right now we have studies, because we can see this kind of post-mortem is not cheap. They're fairly expensive endeavors. And we have a study, for example, this pediatric study alone, from the funding we had, each post-mortem required just about 500,000 shillings to properly classify this disease process for each, right?
We're going to buy around the world.
Just about.
Just about that.
Just about.
So they're not easy. You find we have to rely on donor funding for them. If you look at the active projects currently in the country, the main one is in Kisumu and Siaya, and the reason that was selected, it's called the Child Health Mortality and Prevention Network study, is that there was a realization that deaths in Siaya are just too high. I come from Siaya, so I'm particularly invested in that. But anyway, that's not the reason. So deaths are just too much. We think a lot of it is malaria, but why are we not controlling this death? So we want to look at this and see if we can have lessons from there that can reach policymakers. What we learned is that, especially from the IPOP, is the strength. What is the, what does the patient support group bring to this equation? And as Mr. Gikonyo has said, you shorten that link between science and policy, because you're living with it. You have a lived experience that we don't. So for you, short-circuiting these two policies is particularly quick. So what we want is that in this, what I'd like to challenge you, and maybe in the next meeting, thanks for inviting me, Eunice. In the next meeting, I will have data on sickle cell, specifically sickle cell, because that is an area of interest in our project in Kisumu and Siaya. Here in Nairobi, of course, you hear of autopsy from the forensic side. I know it looks for injuries. It's easier to look for injuries, but this has been knocked by a car and everything. But we also want some degree, especially for the sake of patient safety, to obtain this kind of information where we can educate doctors on how to handle specific groups of patients And we've seen the success with the A project, primary immune deficiency, and also bring that link to policy. And the policy does not have to be Ministry of Health only, and we've seen how international organizations can also come in. I'll stop there.
Thank you so much. Tunapatia makofi. So, questions for all the speakers here. Answer your questions as we wind up.
I wanted to ask a question to Mr. Gikonyo here, and whether, I know as part of safety, there's one big area you did not touch on, and that is the medical legal side. Do you have any comments on medicine, law, safety, especially for individuals who have a lived experience like yours, and potential medical legal areas such as the one you described?
Well, I wouldn't say I have read much about that area, but I would imagine that law would come in where harm has happened and the patient is seeking redress. Now, what I know is that in Kenya that becomes very tricky. And I'll tell you why it's tricky. You need to prove beyond reasonable doubt that there was negligence. For example, either on the part of the healthcare facility or the healthcare worker or doctor. The only people who can give that kind of evidence also happen to be healthcare workers themselves. And now you are creating a situation where one member of Kenya Medical Association is going to High Court to give evidence against another member of Kenya Medical Association. It's not going to happen. However, there are cases which are so blatant and has so much negligence that you first of all annoy your professional colleagues even before the matter goes to court. I recall a case where a woman who was in labor died in Machakos a few years ago, and the doctor who was attending to her had left his assistants to take care of her because he had a game of darts in his local park. So that one, there was no discussion by anyone. He went straight to him. He lost his practice license, and everybody was unanimous. This is unacceptable. We also have malpractices by quacks. You all remember Mugo Wairin? By the way, he's in jail so then there's no place to hide. You will be prosecuted. But that does not mean that if you are done a nasty one in a hospital or in a health facility, that you should just give up because you are going to lose the case. I usually promote something I call do it for the record. If you go to I was having okay, let me give you a story. There's a time I was banking money in the cooperative bank branch of industrial area, and I miscalculated my 5 shilling coins. So I wrote the wrong amount. When I discovered the error and I went to the teller, he told me it's not her job to count my money. So I told her, I'm going to report this case to your superior because you are unable to resolve it. When I went to the superior was in tears. He said, if you make this report, she is on her last warning. She's going to lose her job. But she has already told me that counting my money is not right. So I wanted the bank to employ somebody to whom counting my money is her job. So what am I saying? When you do things for the record, that record piles up. I remember a policeman who was asked at Makadara Law Court by a judge, why is it always you? Yeah, because now a record was piling up, misconduct around him, the same thing, same behavior, same thing, so question marks start rising. So you may not be able to prosecute the doctor. But if the record or the health facility, if the record starts piling up, it will become very difficult for that doctor or that health facility to get client because there will be question marks and people will not be willing to go to them. So, hata kama unajua kesi haitaenda mahali, report. Yeah? For what? For the record.
But just to add on that, sometimes the way I kept on saying, being misdiagnosed, number one. Number two, being given a wrong blood or even being given a wrong medicine to take. That happened to me. I was given a wrong medicine to take. Reason being, our names look alike. So the middle name was the one that was making the difference. But if you write Eunice A. Owino, and the other one is called Eunice at A. Owino, but her is Atieno, I am Achieng. So you will not know, because when the nurse comes, they'll come and tell you it's time to take your medicine, wake up, take your medicine. Yes, Owino, Eunice, take your medicine. Yes. I've seen patients with sickle cell who have been given wrong blood group, transfused, wrong blood, and it affected them. Who are they supposed to go and report to or even sue? Because as I keep on saying, patients with sickle cell, we don't have so much strength to kwenda maandamano. We can never demonstrate and go to the streets and say, haki yetu. But it's important the way you have said. I'm happy I have a lawyer in the house, so he can also guide us in terms of how do we, as patients, make sure that we know our rights, but not actually overwrite and say, I know my rights, so the doctor should not do A, B, C, D to me, or the hospital should not treat me like this. So what are the rights that we need to read and also understand as patients so that it protects us? And also those laws that you told us to read, the laws so that everybody can know what law protects you as a patient, because also those laws are the same laws that when you go to work, you also need to know your right at the workplace. So what are the laws patients need to read? You throw it to the lawyer in the house, or you can
Before you go to the lawyer, I've just remembered. There's a number where you can report adverse reaction to medication. I'm trying to, and if you had gone to the CAPI event yesterday, they could have taught you that. I will find it and I will share it with you. But there's a number you can dial and report adverse disease effects again, so that the relevant authorities can be able to take it up. And that's how I'm sure you've seen some drugs being withdrawn from the shelves and everything. That's how it happens. When those cases become rampant, there's a circular and they are withdrawn. What I'm not sure is whether there's a place where you can report health facilities for malpractices, but when we find that, we'll share. Thank you. Where is the lawyer?
Just before we go to the lawyer,
Where's the lawyer?
Okay, I'll give an example. Was like during COVID, my dad was admitted he had kidney failure, diabetes, what is it called? High blood pressure, and what is this other thing called? ISO. So he was in hospital in KNH actually for 4 months that time during COVID. Then at some point they brought a COVID patient in their ward, and after that patient just passed away. And my dad actually, I think he got the COVID, and now he passed away. It's just the same week. So when we went, we were told that your dad passed away due to COVID. No, not COVID. Due to kidney failure, and in before that, he was really gaining health improving from the dialysis, and when this patient for COVID came, that's when. So we tried to take it up to the hospital and ask them what happened in between this 1 week. That last week he was improving because of dialysis, and now this week you're saying that it's kidney failure. And this patient that died is a COVID patient. How can you take it up in such a case?
But before the lawyer speaks, I can just make a quick comment. Just as and I like what Konya said about knowing your rights as a patient. And each hospital nowadays has to display what are your rights and what's your responsibility. And that is usually the best place to start. If you're aggrieved, what should you do? Each hospital should have its own policy. But then, of course, you have a right to question and a right to seek additional opinions, and also a right to utilize, a right to jurisprudence, which I'm not going to talk about. The doctors don't like me when I talk about this topic, so I'm going to stop it.
There's no doctor. The only doctor.
No, you guys are going to report me, not Dr. Alon said. We must report you. No, but of course those rights are there, and adverse effects, if they occur, they should be internal mechanisms within the hospital, and that's why we are there as pathologists. If there's a mortality, we need to investigate it, give you a clear report and say, this is what we have found as the actual cause of death, and with that information, we can use it internally as a hospital to improve on our policy and on our practice. But definitely you do have a right to all that.
Okay, it's quite unfortunate that where I come from, Uganda, when we just hear of that, they're like Muslims. They either bury the same day, the next day, or like us now, since my dad died in Kenya, so we were given a span of just 1 week to take the body back to home. So we did not go the pathology way. We just needed to. We just need.
We will be left with the question because we don't want our husband mourned by animals. We ask ourselves, what do you want?